Well, good morning. So welcome. It's a cold morning, so thank you for getting here so early on a Saturday morning. So my name's Rob Doughty. There's three of us here this morning. So there's Jamie Voss from the Heart Group, and then Eleanor Natras from Exercise Clinic. This is a session on exercise. Now I think people are going to be coming in, so we're just going to leave the door open, people can come in. We've got 30 minutes and then you've got a 5-minute break and you're going to go to whatever other workshop you want to do. So we're just going to kind of keep cracking through this, but this is your session, so we want to answer your questions. We've got a couple of cases to work through, but please just stop us, talk about whatever you want to talk about, because this is for you. We'll keep moving, but please just interrupt, all right? So this is informal, interrupt. What I'm going to do is kind of just talk through the cases, and then we'll just get this interaction going. So just to get you going, the first case, pretty rare case I would imagine for you to see here. 49-year-old male, annual health check, risk factors have been kind of just drifting, not doing particularly great. And as you can see, elevated blood pressure, high cholesterol, HbA1c's climbing, not on medication, quite overweight, physically inactive, non-smoker, no family history. And they explain they want to get healthy, approaching their 50th, those magic milestones in our life where people start getting a bit worried maybe about their health. Household chores are causing him to be a bit breathless, but he's carrying a lot of weight, and it's kind of starting to annoy him. So you never see anybody like this, do you? Never. Nah, never. So we haven't put specifics on there, we haven't put blood pressure numbers, we haven't put actual weight and those sort of things, but you know the context and you know the discussion around this. So really this is now open. So that's the case to start us going. So what's the advice? So Eleanor's going to start telling you the advice, but what are you going to say? So, what's your advice?
Well, I'd ask him what kind of exercise he's enjoyed in the past, what kind of sport he's done, to get a gauge of what kind of things he might want to do in the future.
Right,
and
yes.
The kind of things he can stick to.
Yep, great, okay.
And also to start slow and gentle, not to kind of sort of throw himself into it.
Yep, okay. Diet, yep.
His family history of
Yeah, so some family history as well, yes, yep. Okay, so Eleanor, so comments about that, so.
Brilliant. I think anyone exercising, whatever they've done in the past, is the best kind of exercise they're going to stick to, is an important bit of motivation that they dislike or are not going to continue. But I suppose one of the big questions for me is, are they meeting or are they going to be able to meet the physical activity guidelines? And does anyone know what the physical activity guidelines are for volume of exercise? Yep, 150 minutes a week. What intensity is that based at, do you know? Where is somewhere? Moderate? Yeah, so the guidelines around exercise are 150 minutes of moderate to vigorous intensity exercise a week. Okay, so moderate intensity is getting to the stage where you can hold a short conversation, not a terribly long conversation, kind of go on the talk test. It's not easy, it's somewhere in the middle where you're starting to get a bit of a heart rate response, starting to maybe get a little bit of a sweat going on. Okay, you could increase that the intensity to help reduce the time, so you could do say 75 minutes a week of vigorous intensity exercise. But again, depending on if he's overweight, if he's got musculoskeletal complications, if he gets symptomatic at all, there's all pieces of information that we need to know before pushing him to low intensity. So he'd fall into that 18 to 64-year-old category of 150 minutes a week. It can be accumulated in bouts of 10 minutes at a time, so the research is showing that accumulating maybe 3 lots of 10 minutes over the day of adequate exercise at moderate intensity will really help, will be cardioprotective, and including 2 resistance exercise sessions a week. So not just looking at the traditional cardio that's been quite focused on, but also including strength and mobility training, again, as he ages and gets that next milestone of potentially getting his gold card. I think it's 65 years old, it's including the balance exercises to aid mobility and make sure that he remains functional and able to do his activities of daily living, which is also fun. Obviously, considering any health conditions becomes important at any stage or any age of the guidelines. Any questions on that stuff there?
So how long should be these two resistance sessions?
The resistance sessions are normally based on like number of exercises and then number of repetitions with those exercises. So the general guidelines are around kind of 2 sets of exercises of about 8 major muscle groups. So that would be things like, major muscle groups would be legs, arms, torso, and you can break them up on days if you like. But the big thing with resistance training is making sure you give your body adequate recovery in between. You do that micro damage to the muscles when you exercise and do that strength training. So 1 to 2 days in between. Hence why it's kind of 2 sessions a week. Okay. Cool? Yeah?
Yeah, many people are now inclined to do yoga and Pilates and stuff.
Yeah.
I just don't know how to quantify them in terms of...
Really good question, because Pilates can be quite intense. It can be included as a resistance exercise session. But then I know forms of yoga as well, like your vinyasa yoga, which uses a lot of skeletal muscle mass and can get the heart rate up, would qualify as like a moderate intensity exercise, but potentially not your yin yoga, which is more your stretching, long periods of stretching. So while some would be considered physical activity and increasing or reducing your relative risk of all-cause mortality and cardiovascular disease by increasing your physical activity, there are greater benefits by increasing your cardiorespiratory fitness. Okay? So there's this idea that that's kind of emerged in the literature in the last couple of decades, that physical activity and cardiorespiratory fitness are independent risk factors. Okay? So you can be inactive but really fit, but you can also, conversely, the other way around, be active but unfit, not having high cardiorespiratory fitness for your age and gender. So I suppose that the message is you've got to try and increase both of them, and any guidelines, or as current healthcare providers, you should be encouraging your patients to participate in physical activity that increases their cardiorespiratory fitness. On to the next slide there, sorry, I just wanted to point out there's a huge amount of wealth of data out there, and this kind of little snippet that I've got here is from the Aerobic Centre longitudinal study in the United States, which pretty much is just helping to show that physical activity, while it will reduce your risk of relative risk of all-cause mortality in men and women, and the higher levels, the more risk reduction you get, but also cardiorespiratory fitness supersedes that risk. Okay, so you get a huge return on investment if you put some time into physical activity that increases your cardiorespiratory fitness. And the biggest risk reduction occurs from when you go from the least fit category. Okay, so kind of like our case study, you go from the least fit category into the next quartile. Okay, so kind of into, say, the 25th percentile for his age and gender. You get about 40% risk reduction on all-cause mortality. So it's huge. It's very important to get the least fit people active. Any questions on that? No? Awesome. All right, flip through to the next one. And this is just, I suppose, another way of getting a really quick snippet of what the risk reductions are, relative risk reductions are, and I wanted to make a couple of points here. So first thing is that we know that physical activity and cardiorespiratory fitness are independent risk factors for heart disease. We kind of just ticked that off. But in the literature, when we compare the active fit category to the inactive unfit category, across the board, so kind of all-cause mortality, cardiovascular disease, stroke and hypertension, which is a few of the cases that I pulled, there's about a 30% relative risk reduction in all-cause mortality, in those conditions, in all-cause mortality. However, that kind of second bullet point under each condition is looking at the kind of systematic review of the literature that has included direct measures of cardiorespiratory fitness. So in the past, a lot of measures of physical activity have been self-reported questionnaires, and maybe when you catch up with your patients, it's asking them how much they do, what their activities of daily living are. But when studies actually looked at quantifying cardiorespiratory fitness, the relative risk reductions that could be achieved are far greater. And the idea behind this is that when you have a direct measure and you know what you're working with, and you can risk stratify them appropriately, you can also prescribe exercise off that direct measure of cardiorespiratory fitness very, very well. So does anyone know how you measure directly cardiorespiratory fitness? No? No, cool. So VO2 max testing or cardiopulmonary exercise testing is we use in the clinic that I work in. So it's similar to like an exercise treadmill test where you have your ECG on, but you also have a little gas mask on that is analysing your oxygen consumption. So the idea being the higher oxygen consumption, the fitter you are. So it gives you a really good idea of where your fitness is and where you sit in the scheme of things for similar genders, similar age ranges, which is quite helpful to know, and then very, very helpful to prescribe exercise from.
How much do you charge for those?
So the session's a really good question. So cardiopulmonary exercise testing, the whole initial consult is $500. So it takes about an hour and a half for the medical consult, and then they get exercise prescription from that as well.
Does insurance cover it?
Some insurance companies do. So Sovereign and Fidelity Life Partners Life do, case by case. Southern Cross has got a rehab review on at the moment. NIB covers it in Australia, not here yet. Yeah, I know. We're working on them. Very, very slowly moving. But generally seem to be pretty NIB and Sovereign seem to be pretty proactive on healthcare and wanting to fund preventative measures as well.
Okay, so no, you're absolutely right. There's lots of other things you're going to advise that individual, including healthy eating and many other factors. But we're just going to kind of keep the exercise theme going a little bit and just change this a little bit. So you obviously follow him up, and he comes back 10 months later, and he's had an acute coronary syndrome event. He's been in hospital. He's had a coronary artery stent as part of the management for his acute coronary syndrome, in and out pretty quickly, as is the way these days. He might be out of hospital in a couple of days even, in many places. And actually his breathlessness now is a little bit better, so maybe that was a bit of angina that he's having, but he's really now determined to really make some of those changes that he hadn't implemented when you'd advised him previously. So now the situation for that individual's changed. So how would your advice change at that point? So it's relatively early after his acute coronary syndrome. He's come back to you quite early. He's quite worried about what's happened, obviously. Very short period of time in hospital. So how would your advice change now, or what would you be doing at that point? I know there's lots of medically kind of stuff to do, but let's focus towards the sort of the exercise components of this individual.
See if he can walk. How many steps he can walk without getting instant?
Okay. Yep. So Eleanor, do you want to?
So I'll be asking him if he's been offered or taken up a cardiac rehab. So cardiac rehab is a class 1 recommendation for pretty much all heart conditions now, especially around stenting. And the great thing with stenting is if someone is clinically stable, then cardiac rehab can start pretty quickly. So cardiac rehab, the cornerstone of it is exercise, and supervised exercise at that. So monitoring, obviously doing either a cardiopulmonary exercise test at the beginning or some form of exercise assessment to see what their functional capacity is, and then making sure the monitoring is ongoing with things like blood pressure and heart rate and symptoms and oxygen levels. Okay, so that would be my first.
But doesn't start till about 6 weeks.
Yes.
So you have to manage that.
Yes.
The appointment doesn't count. You're waiting list.
Yeah, so there's a wait list for, I know. And that's, I suppose, where there is always a wait list for cardiac rehab for the public programs. But yeah, I suppose encouraging exercising between now and then is still a really good time. But also making sure that when they do uptake it at the earliest convenience, as soon as the place becomes open, is really, really important.
Other comments about that situation for that individual? Pretty comfortable with those recommendations?
I always advise them to use a heart rate monitor. So I think in the first part you talked about moderate and high intensity exercise, and also different levels of fitness, they're totally different things. And so I always give them a measure. So for those ones I say don't probably aim to get back to your pre-event exercise level at about 6 weeks. And from then they can build up slowly. I tell them not to exceed in the short term a heart rate of 120. I tell them the second one Q3. Avoid explosive sports, as they don't bother playing squash anymore.
Right.
run up Mount Eden, walk up Mount Eden, don't run up.
Great. Yep.
So that's my side. His heart rate really is a way of monitoring the exercise rate.
Yeah.
Heart rate's quite relative to some of those events as well. So like we see a range of, when we do the exercise test with people, we see a range of maximal heart rates that they achieve. Sometimes they align with the method of 220 minus your age. Sometimes that ends up being quite true, but and other times where it might even be medicated, their heart rate max might be 120 or 130 after they've been medicated.
Well, and I think your point there is really important as well, that actually people's can easily misconceive exercise, I think, that they will go bull at a gate. They used to do that 10, 20 years ago or something. Now they think they want to get fit again, and so they're going to do that. They're going to try and just push themselves until they're kind of falling over going up Mount Eden or whatever it is. So it's actually some very simple practical advice to take that top level of their exercise away. Not that they can't ever do that, but it's actually, proactively talking to people about that, because as I say, many people are they don't view it how we might be viewing it, so we have to assume they're not and make some comments about it. I think it's very important what you're saying. So, yeah. I might just skip that for a second if that's all right. And then what about if this patient had bypass surgery? So they didn't have a stent, had bad multi-vessel coronary disease and had inpatient surgery. So as you'll know, with acute coronary syndrome management, if there is bad multi-vessel disease, really we're living in the era where those people will stay in hospital and they will have their bypass surgery in hospital. So that's a huge event for that person, isn't it? So they're just out of the blue, they've had their coronary syndrome, and the next minute they're on the operating table and they leave hospital and they've had surgery. Just really sort of almost out of the blue for them in a way. So would that change what you're saying and what you're doing, do you think? Eleanor, do you want to kick in there? And
Absolutely. So if we're going a difference between in the rehab clinic from someone having a stent to having a bypass graft, the restrictions for us, or the considerations that we make with exercise, are just around range of motion and strength training of the upper extremity generally, or wherever the surgical sites are. So if they've had grafting taken from their legs, we're obviously very mindful of the surgical site, making sure that's healed before we progress to doing, say, lower body strength training. Likewise, generally 12 weeks post-operative is when we can begin to do some light resistance training with the upper body. Obviously making sure that it's case by case on how the range of motion is going, at what point during the range of motion they're getting any pulling on the chest as well. So it might be that at 12 weeks we start the range of motion exercises that are kind of outside the tube, and then we'll increase the resistance very progressively, very small loads, until they're able to tolerate a 12 to 15 rep range of upper body exercise. So it's really around the physical restrictions post-operatively.
Yes.
If someone had a relatively good baseline before an event, I get questions a lot about high intensity training.
Yep.
Is it dangerous for them to be,
if they're in a monitored, supervised environment and we know what their response to exercise is, we've done an exercise screening, the test, then we quite commonly will use high intensity interval training with our patients for cardio exercise. So they'll be exceeding 85% of their heart rate max for maybe a minute at a time, and then recovering below that for maybe 2 minutes at a time. So it's very, it's a conservative HIIT protocol, if you like. But assuming that, making sure that their blood pressure, their signs and symptoms, there's nothing untoward happening, then if they've had a great baseline before, then they tolerate it really well.
And my only other advice to those sort of people is those people often do go bull at a gate with their exercise, they always have done, and turn it around a bit and actually say, look, you'll get there, but be fit to do it. So, put the effort in to get an aerobic level of base fitness to it, and kind of, that's a lot of mindset change for those sort of people, I think. So, yeah. And just to wrap this one up, do you want to just comment on sort of what are the rehab-related services that are across this region?
Sure, absolutely. So at the moment, obviously, there's the community programs that run. I know the ADHD one quite well that runs at Mount Albert, and Green Lane, so they're 6 to 8 week courses. There's also more and more private facilities popping up. There's a recent push for exercise specialists to be kind of tertiary qualified. So myself and my colleagues who've got a sponsor stand today, we are Master of Science qualified with clinical exercise physiology. So that's our specialty, is working with clinical populations to help them through recovery and rehabilitation. We work with people preventatively as well, but at the moment we are the only physical private clinic in Auckland. There are some pop-up ones starting to happen that are working out of other gyms and things like that. But the exercise specialist you want to be looking for is a clinical exercise physiologist to refer to. Feel free to come and see me at the break, and we can have a chat about it further.
Thank you. So just for the sake of time, we're just going to keep moving. We've got a few minutes still before you change your sessions, and we're just going to change the scenario somewhat now. So 48-year-old female, been very fit and well, some competitive athletic pursuits over her lifetime, still exercising, but now she's aware of these palpitation feelings when she's cycling. She doesn't feel great when that comes on. She sort of loses that power in her legs. She can't keep up what she's doing at that point. Still cycling, but really loses power. And she's wearing a heart rate monitor, and she noticed that it's just 190 beats a minute on a heart rate monitor at the time, and then it'll just go back to her other heart rate. So how would you deal with this kind of person coming to you in this sort of context? Thoughts, comments? What would you say today? That's all you know at the moment. Otherwise, you examine her, she's well, everything else is looking great. So an ECG, so resting ECG, yep.
Maybe a Holter.
Okay, so a Holter monitor, yep. Jamie.
Yeah, I think that's very reasonable. So you're going to see them, evaluate them, take a history. So if it's history examination are fine, then you take a pause. Probably reasonable to do an ECG. On the basis of your examination and ECG, if you think there might be structural heart disease, that's someone that should be referred and seen, or arrhythmia on the day should be referred and seen. If it's a single episode, patient well, there may not be a rush to additional referral. You can go downstream of purchasing a live core, or if you have community access to Holter monitor, that kind of thing. It is important to look for red flags, so things that might suggest structural heart disease, so a murmur, an abnormal ECG. There are features in the history that might make you concerned. So I see exercise-related syncope almost never benign. That's not neurophagic syncope. You can have a simple faint following exercise in a warm environment, but if you have syncope with exercise, that's something that should raise alarm bells. Other red flags I'd see is angina. That's sort of guided by pre-test probability. If you have a young person, no risk factors, tachycardia and a bit of chest pain, that's probably just SVT or palpitation related. But if they've got risk factors and you think it might be angina, again, that's a big flag and have these recurrent evaluation.
So comments, thoughts on that? Any questions related to that kind of context, first of all? Pretty comfortable with that? Yep. So
just before we do that, so exercise, I wouldn't necessarily be restricting their exercise, but I'd be saying to the patient, listen to your body. If you're out training, you get these symptoms, and athletes are terrible when they're in a race. They get these things and they keep going, and they can get themselves into trouble or deteriorate, or they often have to just stop. But I advise them, if you're out there and you're cycling and you get these symptoms, you do have to stop.
So they have some monitoring, and you're lucky that an ambulatory monitor actually picks up the rhythm, because obviously what you're trying to do there is to capture the rhythm, isn't it? And the problem with these sort of people often is it's very intermittent, as Jamie says, so catching it can be quite challenging, and we can talk about that if we've got time. But it's captured to be atrial fibrillation. So what's the relationship between exercise and atrial fibrillation, do you think? None?
Positive correlation with long-term endurance exercise.
Yeah.
I think that's right.
Yeah.
So we think of it as a U-shaped curve. So if you're sedentary, do no exercise, overweight, have cardiovascular risk factors, going to have more AE. And there's a signal in the extreme endurance athletes and to more atrial fibrillation, increased factor of 4 or 5. So it's not that all endurance athletes get it. We don't know how much exercise you have to do to be at risk, but time's probably a factor. We don't see endurance athletes in their 20s getting atrial fibrillation, but it does increase probably in 40s and 50s. The data that we have, people that do ridiculous amounts of exercise, so cross-country skiers participating in 90-kilometre races, and you've done that more than 5 times, you have more AF than if you've only done that 1 time. So in my mind, it's probably somewhere between 10 and 20 hours per week for 30 years, probably increases the risk of atrial fibrillation. So for this patient, it may have no association with exercise and atrial fibrillation. It's actually relatively good data these days about exercise being protective in atrial fibrillation. So a group in Adelaide, led by Crash Sanders and a physiologist, have been very aggressive in the management of risk factors of atrial fibrillation. And this is what they advise for exercise, but this is also in addition to managing lipids, everything else, blood pressure, and much like Eleanor's guidance, 120 to 200 minutes a week, probably up to about 85% of peak heart rate, mostly aerobic, but some resistance training, and 3 to 5 times a day. And remarkably, over periods of as short as 3 months, in people that aren't overweight, 50% reduction in AF burden. Some people come off the elation wait list. And so I think at a population level, this kind of exercise is being done over a lifetime. Light and moderate exercise, you could imagine that there'd be a relatively big primary preventative
So comments about atrial fibrillation, you're comfortable with that, with exercise?
How soon after cardioversion can you start it?
Look, probably. So, in truth, probably the next day. The heart gets used to being back in normal rhythm, and there will be changes to the electrics of the heart in terms of vulnerability in some patients. It's only a minority that truly get AF only with exercise. And so the practical advice might be leave it a few days. But in truth, there'd be no major reason why they couldn't exercise the next day.
Jamie? Yeah.
Just sorry, I probably missed the point that you've already said, but if you're a long distance athlete, like a runner, and you develop atrial fibrillation, you can still continue on.
Yeah, I think so. It depends on your burden of atrial fibrillation. So if we're talking single episode out and undertaking athletic pursuit, I'd be saying to the patient, listen to your body, you get another one, slow down. If it happens every time they exercise, then I think you're going to be advising that person to sort of back off, see a specialist, have they adequately treated, and then you can go and pursue it further endeavours. And there's data out there that suggests that endurance athletes do well with AF fibrillation. They probably don't do too well with a lot of our medicines because they've already got a resting bradycardia, don't like beta blockers for obvious reasons in performance exercise or competitive exercise.
But what if they say that they don't want capitation? For example, if they would rather take maybe medication before they go running, would that be advice?
Yeah, I think so that'll be really now in the realm of cardiologists or cardiac physiologists giving advice on that. But sometimes you can have a small amount of medicine and have things adequately controlled. But getting that balance right between sinus bradycardia rest, side effects, and limitation of exercise performance. Yeah, but the athletic population, the very fit population, are a little bit of a challenge for those reasons.
I'll just come back to what Jamie just mentioned earlier. So you mentioned the AliveCore device. Have you all heard about this or know about it? So one of the challenges with these sort of scenarios is actually catching the rhythm. So you're right, you mentioned a Holter monitor. So a Holter is a 24-hour monitor or 48 hours, but you've got to catch the rhythm, haven't you? So and sort of Murphy's Law is you put a Holter monitor on, that person's going to be the best 24 hours they've had for like 6 years. Then you've got the event monitors that people can have for perhaps a period of some weeks. But again, it's kind of time dependent. How long do you keep the event monitor with the person? And with these sort of quite intermittent rhythms, then if you don't catch the rhythm, what are you going to do? Well, you have to give the advice we've given, but the AliveCore or monitor, I think, really has changed this quite considerably. So, Jamie, do you want to just comment on that little monitor, just what it is? And
sure. So, although I've never downloaded it, you can download it from the internet. It's around $100, I think. and it's an app for your iPhone that uses basically one lead monitoring provided by your thumbs, and it gets reasonable electrograms. And certainly we have a lot of patients after an AF ablation have this and email through to us the recordings, and so they're electronically available. You can't always interpret them, but I think
So-
they have any reason.
So that's it. So that's the AliveCore monitor, and then, as Jamie says, there's an app on your phone. So we don't have a financial investment in this. This has nothing to do with us as the Heart Group. But there's a distributor in Parnell, I think, in Auckland. You go online, Google AliveCore NZ, and it will take you. The first hit is to their website, and they courier it to you overnight or to the patient. And there's an app, and literally the individual has that in their pocket or their bag, and then they just stop and they hold it like that, and it connects through the microphone of the phone. And in the app is software for automated detection of atrial fibrillation. You don't rely on that, but it means it records a 30-second rhythm strip, which can be sent to Jamie, and then Jamie can ponder over it and just tell you what to do with it. But it's fantastic, and it really changes that, because if someone's having symptoms every 3 or 4 months, how are you going to catch it otherwise? It just becomes impossible. So these kind of technologies are really great for these kind of scenarios where things are very intermittent. So quite helpful. So.